So welcome to our second seminar for the 2024 Compass Seminar Series. Our seminar today will be given by Dr. Stephanie D'Souza. As many of you will know, Steph is the Deputy Director of Compass Research Centre. She's also a Senior Lecturer in the School of Social Sciences. Her research uses quantitative methods to examine health, well-being and social outcomes across the lifespan. Steph will be talking about the Kumanu Tāngata Aftermatch Study, which investigates the health outcomes of rugby players using the integrated data infrastructure.
Okay, thank you everyone for coming along today. I've got my name up there, but I've also got my student Fran's name up there because she has been doing some of the work on this project, and I just want to acknowledge her work on this too. As we are using IDI data, of course, I have to put up the Stats New Zealand disclaimer to indicate that these aren't official statistics, but being used for research purposes and do not reflect the view of Statistics New Zealand. Okay, so to just provide some initial background to this study, I'm sure you're familiar with sort of increasing attention, particularly in the media, around the risks of participation in contact and collision sport. Particularly in recent years, there's been more attention towards rugby union, and this is both in the research space as well as the public space. And here are just a few examples of a few headlines that have come out in just within the last year really, around concerns over the outcomes associated with participation in rugby union. And these concerns have been largely driven by the discovery at autopsy of chronic traumatic encephalopathy, or CTE, in the brains of former athletes. And this is a neuropathology that has been linked to repetitive head impacts. Excuse me, in terms of the research that's been out there, there has also been evidence of higher rates of neurodegenerative diseases such as Alzheimer's and motor neuron disease in particular in former contact and collision sport athletes. And two recent systematic reviews published in the last year have indicated that across studies that have been conducted, there seems to be a consistent association between exposure to contact and collision sports, particularly at an elite level of play, and an increased risk of neurodegenerative diseases when compared to individuals from the general population. This includes both hospitalizations related to neurodegenerative diseases as well as mortality. So this indicates both an increased risk of morbidity related to neurodegenerative diseases, as well as a cause of death attributed to neurodegenerative disease. Now, there have also been concerns regarding the mental health outcomes of contact sport athletes, and this is in part due to depression and suicide being linked to chronic traumatic encephalopathy, neuropathological change, or CTE-NC. However, emerging research that's used linked administrative health records in Scottish and Swedish elite level football players and Finnish contact sport athletes more broadly have shown no increased risk, and possibly actually even a reduced risk of mood, substance use disorder and suicide relative to the general population. Now, this is using administrative data, however. And in addition to that, there are also, of course, many health-related benefits associated with participation in physical activity more generally. And a meta-analysis by Runacrest and colleagues on studies of former elite athletes, though not exclusively contact sport athletes, have reported increased longevity as well as a reduced incidence of death due to cardiovascular disease and cancer relative to the general population. In addition to that, the studies that have reported an increased risk of death related to neurodegenerative disease have also found lower all-cause mortality in contact sport players relative to the general population. So what these studies seem to suggest is that while contact sports may increase an athlete's risk of neurodegenerative disease diagnosis and mortality, it may also protect against all-cause mortality and certain mental health conditions potentially, and other chronic physical health conditions such as cardiovascular disease and cancer. To date, however, most of the large-scale longitudinal studies that have been conducted in this space have focused on outcomes for association football or soccer or American football players. In comparison, there is very little evidence with rugby union in terms of the sort of longitudinal research that's been conducted. And this is concerning as rugby union has a relatively high rate of concussion incidents when it's compared to other contact sport. And there's also evidence that rugby has a relatively high rate of other injuries at a professional level, particularly musculoskeletal injuries, when compared to non-contact team sports. However, at the moment, there's only one longitudinal study that's been published using administrative health records to investigate health outcomes in rugby players. This was conducted by Russell and colleagues, and they investigated mortality outcomes in former elite Scottish international rugby players. And what they observed in their study was that players had over 2.5 times the rate of neurodegenerative diseases compared to the general population. However, with the Russell study, they had a relatively small player cohort, just over 400 players, resulting in a low count of neurodegenerative disease outcomes, which as a result means that there was reduced statistical power and limited precision in their estimates, so quite wide confidence intervals just because of low case numbers, particularly for some of the types of neurodegenerative diseases, such as motor neuron disease. When looking at also, so this is just what I've covered so far is players compared to the general population, but then when also looking at player-specific risk factors, research from American football and soccer have suggested that there may be evidence of a dose-response relationship between participation in contact sport and neurodegenerative disease risk. So, for example, some studies have shown that a longer career duration or playing at a professional level rather than an amateur level may increase the risk of neurodegenerative disease outcomes among players. However, this hasn't consistently been observed in the literature. It seems to vary. Some studies show it, some don't. And the same also seems to apply to player position. There has been an increased risk observed for playing positions that are typically associated with a greater number of head impacts in soccer. But the study by Russell and colleagues found that there was no difference by playing position with the international rugby players in Scotland. So with regard to sort of these player-specific factors, results in general seem to be quite mixed. So based on the general sort of lack of research in this space, particularly for rugby union players, this motivated the development of the Kumanu Tāngata study. So this study is a collaboration between New Zealand Rugby and the University of Auckland. The project name Kumanu Tāngata was gifted by New Zealand Rugby's kaumatua, Luke Crawford, and it comes from the phrase he tukutuku rāronga he Kumanu Tāngata, which literally translates to a statistical lattice work cherishing people, and more figuratively translates to the idea of multiple data threads coming together to sort of to care for our players, look into player outcomes. And the name or concept of Aftermatch is a sense of what lies beyond a professional sporting career. So looking at health outcomes after their sporting career, but also Aftermatch within the game is also an opportunity for debrief and analysis. So sort of taking that term and applying it here as well. So with the Kumanu Tāngata study, what we did was we utilized the integrated data infrastructure to investigate, our aim is essentially to investigate a wider range of health outcomes and be able to use a considerably larger sample size than what has been done before in this sort of space. So for some background on the IDI, it is a population-based linked administrative database that's maintained by Statistics New Zealand and contains de-identified data on individuals from government and other sources, including comprehensive health records. New Zealand Rugby were able to arrange for the New Zealand Rugby Register, which was compiled by New Zealand Rugby historian Clive Akers, to be linked to the IDI spine, which is an ever-resident population based on tax, birth, and visa records. And this register contains a list of New Zealanders who played rugby at a first-class level. So this is at a provincial or higher level. And they were active between 1950 to 2000. So these were the individuals that were linked to the IDI. This was about 16,000 records that were provided to Statistics New Zealand, and we were able to successful link. We didn't do it. Statistics New Zealand did it, but successful linkage was achieved for about 86% of players. We applied some additional exclusion criteria, which hopefully you can see. I think you can see all right. But essentially it was based on data availability, age, and the possibility of linkage errors as well. And we tracked the players we'll track the individuals from age 30, which was when most of the players had finished their career. So following all these exclusion criteria, our final sample consisted of about 13,227 players who were born between the years 1920 to 1984. So this particular study design, this retrospective cohort design, as I said, results in a relatively large sample size than previous research that has used administrative data to look at health outcomes in contact and collision sport athletes. This means that we are able to get a greater case identification for rare outcomes, such as neurodegenerative diseases and certain types of neurodegenerative diseases, resulting in, as well, increased statistical power to detect effects. We then had a population comparison cohort. So these were males in the general population, the general New Zealand population, and they were within the same age or birth year range as the players. Now, there were demographic differences, obviously, between the players and the general population of the comparison group. What we've got up here are the players in the green bars, the population originally in the black bars, and you can see that there are differences. For example, there's more Europeans amongst the players, more Maori and Europeans, as well as more New Zealand-born individuals with the players. And there were also some birth year differences, though I don't have that up here as well. So what we did to control for these demographic differences between the players and the general population was a method of direct standardization to weight the comparison group to match the players in the distribution of total response ethnicity, birth year, and their New Zealand-born status. So you can see after weighting in the grey bars, the percentages essentially align up with what we see for the players. I haven't shown it for the birth year bands as well, but we see the same results, essentially the same percentages as the player group after weighting. And these were our particular outcomes of interest, which were, of course, informed by what has been looked at in previous literature. So each outcome, our goal is essentially to look at each outcome within a different study, or specific study focusing on an outcome. And we tracked our outcomes between 1988 to 2018 based on when the data were available in the IDI. And we tracked this, as I mentioned, following the 30th birthday based on when most players had ended their playing career. We ascertained each of these outcomes of interest using ICD codes from primarily hospitalization and mortality records. In some cases, pharmaceutical conditions were also examined where possible, where there's certain prescription medication being applied. For neurodegenerative diseases, what we were interested in was any neurodegenerative disease, Alzheimer's disease, other dementia, Parkinson's, and motor neuron disease. And with our chronic conditions, these include cardiovascular disease, cancer, and diabetes risk as well. With mortality, we will also focus on all-cause and cause-specific mortality. What I'll be talking to you about today, though, will just be the neurodegenerative disease results, because that's what we've been primarily working on so far, and we've sort of started some work underway with mortality as well. So in addition to comparing players in general to the comparison group, the general population, we also looked at player-specific variables, which included exposure to the sport, which was measured based on years played and matches played. There was also, and I should say, when I say years played, this is the number of years that they played at the first class level, so provincial and higher. We don't have information on how active they were in lower levels of rugby. Playing level was based on whether or not the individual played at an international or professional level. So rugby was professionalized around 1996, towards the end of when players were active, but they would have been playing sort of at a similar level, and some would have been playing internationally as well. And the rest who weren't playing at that level were categorized as either provincial or first-class amateur players. So that international professional group included those who represented the All Blacks since 1950, those who played in the New Zealand Professional Super Rugby competition as well. And the provincial group is players who represented one of the 27 provincial rugby teams that were active since 1950. Playing position was typically was categorized as either forward or backline players. And forwards, I don't know how easily you can see that text up there, but the forwards are essentially these positions up here, and the backs are these positions down the bottom. Forwards are typically larger players charged with gaining possession of the ball and are typically involved in more tackle events, whereas backs tend to be smaller, faster, and tasked with gaining field possession. Now, to examine the risks of neurodegenerative diseases, players and the general population, between players, and the general population, and to also evaluate the risk for these player-specific variables, primary analyses were conducted using Cox proportional hazards models to obtain a hazard ratio. So for over a mean follow-up period of almost 24 years, 606 players, or 4.7% of our players, were identified as having any neurodegenerative disease, compared to 3.9% of males from the general population, which was over 92,000 individuals. With our hazard ratios, what we found was that rugby players were more likely to be diagnosed with any neurodegenerative disease, Alzheimer's disease, and other dementias than the general population males. But we didn't observe any significant results for Parkinson's disease and motor neuron disease. And then with our player-specific analyses compared to the general population, an increased risk of any neurodegenerative disease was observed for provincial, first-class amateur players, professional or international level players, those who had a high level of exposure in terms of matches and years played. So that was 6 or more years of play, or 21 or more matches, as well as those in a backline playing position when compared to the general population. In addition to that, players in forward positions also had a lower risk than the backline players in terms of any neurodegenerative disease risk. So I've presented the hazard ratios here for any neurodegenerative diseases, but we also saw these specifically for Alzheimer's disease and other dementias as well. And we've just got a visualization here of the playing level with the comparison to, what's shown up here is the hazard ratio for the provincial amateur level players in blue and the international professional players in red compared to the general population. And so it might be a little bit hard to see as well, but we've also got the visualization here of this for the years and matches played, again, compared to the general population. And the way that we did it was we converted these variables into tertiles, categorized. So for years played, they were active for a year, 2 to 5 years, or 6 or more years at the first class level, or they participated in 1 to 4 matches, 5 to 20 matches, or 21 or more matches at the first class level. And as you can see, we've got particularly significant effects in relation to Alzheimer's disease and other dementias when it comes to greater exposure of play. All right, so to bring that all together, what we observed was an increased risk of neurodegenerative diseases for high-level rugby players. And this was particularly for those that had a high level of exposure and those that were backline players. The effect of backline players having an increased risk was interesting, because forwards tend to be more likely to be exposed to contact activities such as tackles and rucks. However, some other research has shown that backs are actually more likely to experience head injuries related to these tackles, or even though they don't engage in tackles as often as the forwards do. And this could be possibly due to the speed and the direction of tackles that are resulting in these injuries. And this increased risk, while we weren't able to, of course, measure this, we think is possibly due to more accumulation of brain trauma. And yes, I do mention that. So the previous research was conducted both in American football, in rugby, but American football, a study with American football also found that speed players were more likely to have neurodegenerative disease outcomes than non-speed players. So similarly, the speed players would line up with our backs, who tend to be engage in more speed play than the forwards. So just a few caveats, of course, with this. With the fact that we're using service use data, administrative data, there is the likelihood of undercounting cases, and we don't have any access to primary care data where a lot of cases would also get picked up. As I mentioned, we also don't have any direct measures of exposure to rugby-related factors like repeated head impacts. So while we're seeing these associations, we don't have a direct measure of what may be underlying the association. And rugby has changed quite considerably in recent years, particularly with the shift to professionalism. And as I mentioned, that occurred towards the end of when our players were active. So our players were active between 1950 to 2000, and rugby became professionalized in 1996. Since then, there have been changes to player build and impacts, as well as the ethnic composition of the players, which means that results may be different if we were to look at players that were active right now. And of course, as well, because we focused on males, we can't say whether or not our results would generalize to female players as well. So our next steps would be, as I mentioned, to look at mortality, and we've also got starting to get underway with looking at musculoskeletal results as well. And we'll hopefully have these results published in the next few months too. Before I finish up as well, we've got a decent amount of time for questions, which is good. I just want to give a quick acknowledgement to Dr. Ken Quarry from New Zealand Rugby, as I mentioned, Fran, who did a lot of the work and is doing some of this as part of her PhD. Barry, of course, Chow, who's part of the Compass research team too, and has helped a lot with the analyses, and in general, the wider Kumanu Tāngata research team. World Rugby and New Zealand Rugby, who've provided World Rugby and New Zealand Rugby Foundation, who have funded this research. Statistics New Zealand, of course, for access to the IDI and linkage of this data to the IDI. And finally, the Public Policy Institute here for access to their data lab. And that is it. Thank you.
My assumption would be that the forwards would be the ones.
Yeah.
It makes perfect sense having heard your explanation.
Yeah, it is an interesting, I don't think we really,
Counterintuitive.
yeah, it is counterintuitive. We were a little bit surprised initially, and then we kind of looked into the literature a bit more and we're like, okay, right. It's, you know, it depends, and it's still sort of mixed, and there's again not a lot that's actually looked into it in terms of rugby and playing position. But yeah, yeah, unexpected finding a little bit there. Yeah, thank you.
Did you look at the number of cases of concussion in the rugby population versus?
No, we don't have good data for that, to be able to actually look at concussions. I'm trying to think what would be there, because not all of them, because it's based on service use, and not all of them would have gone necessarily to hospital or whatever they might have, right? Yeah. Yes. Yeah, you're right, actually, yeah. Because of when they would have been active, it would have been 1950 to 2000, but the hospitalization and mortality, hospitalization records only start from 1988 onwards. So we wouldn't actually even be able to look at concussions while they were playing. Yeah. But that would be great if we were able to. We have a question here that says, what is New Zealand Rugby doing with the research? Which is a great question. I think this is both for New Zealand Rugby and to feed back to World Rugby as well, for them to initially get an understanding of what the outcomes look like for rugby more generally. And from that, I think to realize where they need to prioritize their focus. So I think they are looking more into, I can't speak for what, you know, New Zealand Rugby and what they're going to do. We're just sort of there to present the results and the data, but you would hope that their action from that is to look at sort of more preventative measures to minimize head impacts, which I think they're starting to look at measuring it at least more effectively with some of the mouth guard tracking that they've got going on. And I guess hopefully use it to inform future sort of athlete care strategies. Yeah. And then Lisa said, did you find any differences across ethnic groups? Are you able to take into account how young players were when they started playing rugby at the levels? We did have ethnicity information. There would have been, I can't remember off the top of my head if there were differences by ethnicity. We do have, the numbers are quite small for basically anything that is not Maori or European. And particularly at the time, there would have been a lot of primarily European players. I can have a look at that and actually let you know. But in terms of age, how young players were when they started playing rugby, no, we haven't looked actually at whether age, whether when they started playing has any effect on later outcomes. Yeah, so that could be something that we could look into. It would be interesting.
Reporting of concussions, rugby, is it now mandatory or not? Never used to be.
I don't know actually.
Highest level it is.
Yeah,
Don't know about the lower level, so club rugby.
yeah,
But either way, it's recent.
Right.
So certainly back into the 1950s through to the 1990s, it was no mandatory reporting.
certainly not where they've got. I think if it was recorded or they had it, they would have probably added it to the register. You'd hope.
But I don't think they report the rugby union. That's the thing.
Right. Yeah.
Yeah.
Mm.
I don't know. It's a really good question.
Yeah. Well, we can ask Ken and say, but I imagine he would have already wanted to look into it if it was there. Yeah.